Hi again, and welcome back for the last section of hematologic. It's just been a long process, but we're coming to the end. So let's go ahead and move into hemorrhagic disorders and alterations in platelets, and these will be diseases that cause patients to bleed. So let's start with the disorders of platelets. I'm going to try to keep these simple and basic just so you have a good overview of what things mean and some just basic information about it. So normal platelet levels are important to know. And again, it depends on the lab that you're using, but in general, about 150,000 to 400,000. When we have a disorder of a platelet, it can include issues in quantity of platelets, quality of platelets, or actually both. And remember, thrombocytosis, increased cells, increased platelets, is an increased level of platelets, and thrombocytopenia, penia being small, a small amount of platelets or decreased levels. So thrombocytopenia is less than 150,000 platelets. So whatever your bottom number for your lab is what you would use. So anything less than the normal value. Low platelets. So when you think low platelets, you should be thinking bleeding. Hemorrhage is associated with minor trauma, does not appreciably increase until the count falls below 50,000 platelets. Kind of interesting when you have 350,000 and really don't have any issues until the count falls below 50,000. And that's with a minor trauma. But that's an important number to remember, 50,000, because that's when there may be some intervention. Spontaneous bleeding without trauma, okay, this one is a trauma, can occur with count ranging from less than 10,000 to 20,000. So you can kind of see here 20,000 prophylactic in patients at risk for bleeding due to infection, coagulopathy. So 20,000 is kind of another marker here. Spontaneous bleeding without trauma can occur when counts are from 10 to 20,000, depending. So in this case, we'll say less than 20,000. But surgical bleeding with counts less than 50,000. So we can have some spontaneous bleeding in a patient, and when trauma is not even comes into play, we do become a little concerned when platelets get below 20,000, okay? So there could be some prophylactic transfusion in patients who have a risk for bleeding when their platelets get to be 20,000. But if it's a surgical patient, we become concerned if their platelets get less than 50,000, okay? Counts less than 10,000 can result in skin manifestations, ecchymosis, purpuric spots, or frank bleeding from mucous membranes. So sometimes 10,000 can be the marker when we determine if somebody should get a platelet transfusion. Severe spontaneous bleeding may result if the count is less than 10,000 and can be fatal if it occurs in the GI tract, respiratory tract, or central nervous system. Okay, that's becoming very concerning. Platelet transfusion guidelines, platelets less than 10,000. Prophylaxis transfusion is generally recommended less than 10,000 to prevent bleeding. What about transfusion here? Prophylactic in patients who are at risk for bleeding. Then we care at less than 20,000. When they start getting below 20,000, then they are going to warrant a platelet transfusion. Due to an infection, people who are on chemotherapy, people who have coagulopathies, that becomes a little bit a different guideline, okay? So less than 10,000 just for the average person, less than 20,000 for somebody who's at risk for bleeding, less than 50,000 if somebody is actively bleeding or prior to an invasive procedure or surgery. So don't have to make this difficult. So these are some numbers you should keep in mind. Transfuse somebody if they're less than 50,000 if they are going to have a procedure or if they are actively bleeding, like they're still bleeding, they have a GI bleed, they're still bleeding, and surgery. Less than 20% if they're at a risk for bleeding, and less than 10% just with pretty much with everybody else. And that will be helpful for guidelines for you. So thrombocytopenia results from decreased platelet production, which we just talked about, increased destruction, or both, maybe either congenital, something that they're born with, or it can be acquired, and acquired is more common. Generally, they're secondary to viral infections or drugs or chemotherapy. There's multiple reasons. Most common forms of thrombocytopenia are a result of an increased platelet destruction. There's something that is destroying somebody's platelets. And again, it can be a viral infection. Drugs are common. The spleen can also hold on to too many platelets. It normally stores about 1/3 of the body's platelets. But if it decides to hold on to more because there's something that's not acting, the spleen's not acting right, that can contribute to some low platelet counts. And this is just a little slide of symptoms of thrombocytopenia. Low platelets. Low platelets are going to cause excess bleeding, fatigue and weakness, easy bruising, headaches, and blood in the stool and the urine. So these are some symptoms that can be concerning with low platelets. So let's talk about some causes of common thrombocytopenia. Okay, so we're just going to talk about, I think we're only going to talk about 2 of them. And the first one is heparin-induced thrombocytopenia. So this is a secondary, somebody's got thrombocytopenia, low platelets. They were totally fine. There's nothing wrong with them. Their spleen's fine. They don't have any cancer. It's just they got heparin. And when they get heparin, sometimes they can get a thrombocytopenia. Heparin is a common cause of a drug-induced thrombocytopenia. Approximately 4% of individuals treated with unfractionated heparin develop HIT. How about that? 4 out of 100. That's why unfractionated heparin is not used nearly as much as it was used in decades ago. So an unfractionated, or just the regular heparin versus a low molecular weight heparin, there's much lower incidence in HIT with an unfractionated heparin like a Lovenox. About 4% of individuals for heparin, and it's less than 0.1% will patients in enoxaparin or a low molecular weight heparin. That's why that's used so much more, and rightly so. The hallmark of HIT is thrombocytopenia. We draw a lab and like, whoa, look at this big dip in this person's platelet level. A decrease of approximately 50% in the platelet count is observed in more than 95% of the individuals. And that's typically how it's found. That's incidentally found, because even though their platelets are low, they don't always bleed. Okay, so if their platelet level goes from 400,000 to 200,000, or 350,000 to 175,000, they lose 50%. That doesn't necessarily mean that they're going to bleed. But if they do lose about 50% of their platelet count while they're on heparin, it's concerning, and they should be taken off of heparin. The individual presents with dropping platelet counts after 5 days or longer of being on heparin. So it doesn't always happen right away. And sometimes these people have gone home. They've gone home and they may have some thrombocytopenia that no one ever knows about. Or maybe they just go to the doctor for something else, get some lab work, and they incidentally found it. Or maybe their original platelets were low enough that they actually do start having some bleeding and bruising. And if that occurs, we always want to draw some platelets to see what they are. On average, platelet counts may fall to 6,000, so they can fall that low. Treatment is the withdrawal of heparin, generally, period. That's usually all we need to do. and if we need to give them an alternative anticoagulant, another one that doesn't cause HIT. This is just a little picture of kind of what I talked about. So the heparin is an anticoagulant that prevents blood clotting that somebody would be getting because of a blood clot. And what it does is it decreases the number of platelets, which we call thrombocytopenia. So HIT is a complication caused by heparin that causes decreased platelets in the blood. That's very basic, and that's what I want you to know about it. The second one that I want to talk about is immune or idiopathic thrombocytopenia purpura. And it's exactly what the name says. It is an idiopathic, don't know the cause, thrombocytopenia, low platelets that cause purpura. Okay, ITP. Oh, I should put that here. So I have it in here, but put ITP here because it's really what it's referred to most of the time. The most common cause of thrombocytopenia, secondary to increased platelet destruction from maybe chemotherapy, is actually this ITP. So this is the most common thing that we see in patients, and it may be acute or it may be chronic. So acute is caused by an antigen like an infection, CLL, which is the chronic lymphocytic leukemia, lymphomas. So it can be caused by something like that. It resolves once the source of the antigen is resolved. So sometimes patients are just in the hospital and they come in with pneumonia or they have some type of an infection. And next thing we know, we're drawing CBCs and we're like, whoa, this person has thrombocytopenia. This person has low platelets. They're not on heparin. Nope, they're not on heparin. They just have a drop in their platelets, a significant drop in their platelets. And that's the first indication that they have developed this ITP over and beyond the reason that they actually were admitted to the hospital. Chronic is caused by sometimes people just form antibodies that fight their platelets. But the acute ITP is seen a little bit more commonly. Initial manifestations range from minor bleeding problems, develop a petechiae, purpura. They just have these bruises and these red purpura spots that just show up for no reason. They don't know why their skin is turning these purple colors. Thrombocytosis. Thrombocytosis increase osis in a platelet cell, defined as platelet count greater than 450. And thrombocytopenia may be primary, it may be secondary, and is usually asymptomatic until the count exceeds 1 million. How about that? Okay. So we have a primary thrombocytopenia, which is called essential thrombocytopenia. And when somebody has essential primary right here, ET or essential thrombocytopenia, it's a defect in the bone marrow and too many platelets get produced. So they just have too many platelet cells occur. And when they have essential thrombocytopenia, which is due to these mutated genes that just keep proliferating and multiplying, they have this thrombocytopenia and it's diagnosed as essential thrombocytopenia. And most of these patients are positive for that JAK2 gene. And remember, the JAK2 gene can be present in somebody who has thrombocytosis now, and in somebody who has polycythemia vera. So JAK2 is a gene that's present in somebody who has polycythemia, too many red blood cells, and thrombocytosis, too many platelets. Kind of helpful to know that's a kind of a common gene that's tested for. So primary is essential versus a secondary thrombocytosis, which could be caused by a splenectomy. So somebody gets their spleen removed for whatever reason. Maybe somebody has a trauma and their spleen breaks open. They have to have their spleen removed. So after splenectomy, because platelets that would normally be stored in the spleen are now just circulating all around, and they have this high platelets, and it's not a genetic problem. It's caused by something else, a trauma or something that caused the person to lose their spleen would be probably a pretty good example. So what are clinical manifestations? Clinical manifestations are blood clots. So initial diagnosis is not difficult. And as many as 2/3 of the cases are diagnosed from just a routine CBC. You're going to draw lots of CBCs on your patients when they come in with multiple complaints. Like, well, let's take a look at your blood count. We get the blood counts back. That's what we've been talking about over the last 6 lectures. And get a CBC, and you see some thrombocytosis. And that should be a red flag, right? That should be a red flag that you can kind of think about, why would this person have thrombocytosis? If it's not something that you can figure out, then obviously they would need some type of a referral because, you know, they're going to have clots, and that's going to be something that could be dangerous with them. Some treatment for essential thrombocytosis, I'm sorry if I called it thrombocytopenia, I'm wrong if it is thrombocytosis, is actually directed toward preventing thrombosis, preventing the blood clots, and reducing the platelet count is important for treatment. That's the goal of treatment. So the myelosuppressive agent of hydroxyurea, which we have talked about, actually is the drug of choice to prevent that kind of proliferation of that mutated the overproduction of platelets. And somebody can have phlebotomy. If their platelets are too high, they can just get some phlebotomy, just draw some blood, throw it out, and that could help for them as well. Oops, I'm sorry. I didn't know that you had this slide right here. So this is my fault. Okay. Thought I just said all that stuff. Okay, let's move to the second section, which is disorders of coagulation. I know this sounds like a lot, but again, I'm just going to really be brief with all of these. And just keep in mind now we're talking about a disorder of somebody being able to coagulate or disorder of coagulation, so they have an inability to clot. We just talked about somebody who has a propensity to clot. This is the inability to clot or very slow clotting. The first one here, when we talk about something that can cause an impaired homeostasis, is vitamin K deficiency. That's important for you to understand that vitamin K, which is a fat-soluble vitamin, remember the fat-soluble vitamins are A, D, E, K. That's good to have in your memory. And vitamin K is required for synthesis and regulation of prothrombin. Okay, and so prothrombin is necessary to change fibrinogen to make thrombin, to change fibrinogen into fibrin. Or liver disease. The liver cells produce most of the factors, the clotting factors involved in homeostasis. Therefore, damage to the liver frequently results in a diminished production of vitamin K and clotting factors, because our vitamin K is actually made in the liver. So these would be two things that would cause somebody to have a vitamin K issue here, and it would cause them to bleed. They would have a more propensity to bleed because you need vitamin K for your clotting factors, period. So the first one we're going to just briefly talk about is hemophilia A. Now there are two different types of hemophilia. Hemophilia A being the most common, and you've probably heard of this. It's an X-linked recessive bleeding disorder. So most of them are inherited, and most of them are inherited from mom, because mom has two X's. So she usually gives, it's an X-linked, dad gives X or Y, and mom gives the X. And it is a recessive disorder. So 1 in 4 chance the child has, and 1 in 4 that the child has a chance to get the disease. So what is hemophilia A? It's a deficiency or an abnormality in clotting factor V111, which is 8. Circle that. It's a deficiency in clotting factor 8. It's not a deficiency in vitamin K due to a poor intake or due to a liver disease, which helps make vitamin K. It's a deficiency in clotting factor 8. That's what I would know if I were you. It varies in severity. Somebody can be severely hemophiliac or have a very mild case of it. Generally, this is found in childhood. Okay, so this is something that is picked up early on. Generally, we don't just pick this up in an adult. They know by the time they're adults that they are hemophiliac. Manifestations, just understand that they're going to have bleeding and just know the signs of bleeding, bruising, petechiae, bleeding under the skin, that type of stuff. Purpura. How do we diagnose it? Well, they get clotting studies. They manifest some type of bleeding tendency when they're younger, and they get some blood work, and they draw clotting studies and serum factor 8 levels, and they see that the factor 8 is low. Treatment, well, they get clotting factors depending on if it's a mild, moderate, severe. Sometimes they need no treatment, and sometimes they need these transfusions of clotting factors so they can get factor 8, okay? And they're on bleeding precautions. We want to be careful with them as far as using razor blades and hard toothbrushes and things like that. So bleeding precautions is something you're aware of. The second one is von Willebrand's disease. And von Willebrand's disease is actually the most common hereditary bleeding disorder. It's like hemophilia is more common to us for some reason, because that's what we've heard about, but it's actually not the most common. Von Willebrand's disease is the most common, okay? About 1% of the U.S. population has a von Willebrand's disease. So 1%, 1 out of every 100 person that you're going to see as a provider has it. So again, it's important to at least know what these things are and be able to critically think and know that it's going to be something that is going to cause them to bleed, because I know we can't remember everything about everything, but at least be able to recognize it. There's a decrease in platelet adhesion aggregation. So there's a protein that called von Willebrand that helps platelets stick together. So platelets stick together with the help of von Willebrand. In a healthy, that says PET. In a healthy patient, bleeding stop because the platelets stick together and form a clot at the site of the injury. Okay, but with von Willebrand's disease, clot formation does not happen as it should. So see how this platelets aggregate? The platelets are not aggregating. Okay, so hence they have a clotting problem. So this von Willebrand's disease is results in the deficit of the von Willebrand factor, and there are 3 types, and the 3 types are just an indication of severity. Type 1 is the most common, type 3 is the least common, and that's good because type 1 is very mild. Sometimes they don't even have any symptoms or any problems. Type 2 is more moderate, is a little more moderate instead of mild, and the body still makes the von Willebrand factor with 1 and 2. 1 works a little bit better, and in 2, the von Willebrand factor is made, but it doesn't work very well. Okay, so hence their platelets don't stick together. And then 3 is the most severe. Sometimes their body doesn't even make hardly any von Willebrand factor. So again, 1 being the most common. How do we treat them? We can give them clotting factors. We want to tell them measures to control their bleeding, prevent injuries. If they fall and hit their head, they would have to go in and get evaluated. Just things like that should make sense for somebody who has a propensity to bleed. The next one I want to talk about, and I believe there's, I guess just 2 slides on it. I know it looks a little bit busy. It's a little less complicated than it looks, so just kind of bear with me. So disseminated intravascular coagulation, or DIC, which would be more prevalent for somebody who's working in an acute care setting versus somebody who's working in a primary care. But somebody could go to the hospital and have DIC, and so again, it's something that you should know about. It's an acquired, it happens because of something generally in the hospital, clinical syndrome characterized by a widespread activation of coagulation resulting in formation of fibrin. That should trigger something in your head, so that makes you think clots. Fibrin is the last step of the clotting cascade, so resulting in the formation of fibrin clots in medium and small vessels throughout the body. DIC is secondary to a wide variety of well-defined clinical conditions, meaning it is caused by these things. There's multiple things that can cause it. Probably the most common thing that happens to a person, a clinical condition that happens to a person, is they become septic and they have which is a severe infection. That's number one. Number two is trauma. So they may go in the hospital because they're septic because of a UTI, but they might develop or acquire this DIC on top of that. So sepsis is a common cause. Trauma is a common cause. Liver disease, somebody who has cancer or malignancy, and the OB calamity. So sometimes somebody goes in childbirth and they develop DIC while they're in labor and delivery, which I'm going to talk about the mechanism here. So what happens when somebody goes into DIC, they come in for something else and all of a sudden now they got this new horrible diagnosis of DIC. It's a widespread clotting that may lead to blockage of blood flow to organs, resulting in multiple organ failure. So all of a sudden the body just starts making clots, okay? Bad. You can imagine these clots traveling around in the vessels and just blocking blood flow to all the organs. Then the excess clotting may result in consumption of platelets. The platelets get overused. The clotting factors get overused, and they run out. They just run out of platelets and clotting factors because so much is used because of this massive clotting that's going on. And it leads them to a tendency to bleed, despite the fact that they have clots all over their body. So it's a clotting and bleeding problem. Imagine how disastrous that is. Whatever the trigger is, something here or something else, but these are things that we see most commonly, causes this increased clotting to occur. And with the increased clotting, we have the consumption of platelets and an increased consumption of the clotting factors. They run out, and that leads to thrombus formation at the site of injury in microcirculation, a hemorrhagic syndrome called DIC. So you should understand the major components to this. And again, its prognosis is better than it used to be, but this is just something that can be tough to recover from. So some clinical manifestations, most symptoms are the result of either the bleeding or the clotting, right? So they have these types of symptoms with DIC when they bleed. So the ecchymosis, hematomas, blood in the stool, blood in the under the skin. They're pale. They have blood in the urine. They're bleeding from all different areas, their nose, their mouth. And then they have clotting issues and symptoms that they're going to getting chest pain and shortness of breath because they have a clot that got thrown to their heart. They got a clot that got thrown to their lung. They're getting DVTs. They have clots that get thrown to their extremities. They could have headaches, speech problem, dizziness, strokes, anything that a clot gets thrown to. So every single organ in the body becomes affected. Acute DIC presents with rapid development of hemorrhaging or oozing from venipuncture sites. So they got IVs in and the blood's leaking around them. Arterial lines, same concept. Surgical wounds, development of ecchymosis lesions, purpura, petechiae, and hematomas. So we see these start to develop on them. Other sites of bleeding include the eyes, the nose, and the gums. Most individuals with DIC demonstrate bleeding at 3 or more unrelated sites, and any combination may be observed. Shock of variability intensity out of proportion to the amount of blood loss. So that might be observed, meaning that somebody's going into shock and you're like, wait a minute, they just bled a little bit from their IV. How could they be going into shock? Because hemorrhaging into closed compartments of the body can occur. They could be hemorrhaging into their belly and they can be hemorrhaging into their head, and then that could precede the development of shock. So again, it's just important to understand what DIC is. Evaluation and treatment. Persons with DIC should be treated at the hospital with appropriate critical care, expertise, hematology, blood bank, surgery. This is a big deal. No single laboratory test are used to diagnose DIC. It's just multiple lab values. Diagnosis is based primarily on clinical symptoms and confirmed by a combination of lab tests, which you don't need to memorize all the lab tests because there just really is a lot, but these are just some that you can see how that can be very helpful in regard to diagnostic. So let's just take a look at these right here. Lab findings in somebody who's in acute early phases of DIC, right? They're bleeding, okay? What does lab values look like with somebody bleeding versus when somebody's not bleeding? So the platelet count would be low. This is somebody who's bleeding right now. Fibrinogen is low. If fibrinogen is low, fibrinogen trying to change a thrombin to fibrin, or thrombin changes fibrinogen to fibrin. If the fibrinogen is low, the fibrin is low. Okay, so low, no clotting. PT and INR and PTT, up. They're both up. Bleeding times. How long does it take for your blood to clot? 1, 2, 3, 5, 10, 20 seconds. Those get longer and longer and higher and higher. It takes their blood a long time to clot. Remember a D-dimer, we talked about that. That gives us an indication. It's one of the fibrin degradating products, FDPs. And the D-dimer gives us an indication that there is increased FDPs in the blood, which means there's clots that are breaking down. And it would certainly be something. The peripheral smear we really haven't talked about. So you don't have to memorize these, but the reason I have them here is I want you to make sense of those. It's important that those make sense to you in regard to somebody who is bleeding. Thrombophilia is, want to talk about thrombophilia. And we have the first one here that I want to talk about, the only one I want to talk about, is this factor V Leiden deficiency. So there are other hereditary thrombophilias that are not as common, but the most common one that you should know about is the hereditary thrombophilia factor V Leiden deficiency. Okay, and what happens with this is it's a hypercoagulable disorder. There is something wrong with the factor V gene right here, and it's hereditary. So if somebody has it, their family members need to be checked for it. And they are prone to blood clotting. They get these blood clots that form, and you're like, why do you have a DVT? Why do you have a pulmonary embolism? There really isn't anything that provoked it. So if there's nothing that provokes these clots from forming in somebody's body, they have to be suspicious about a couple things. One is this right here, a hereditary thrombophilia factor, and a hereditary cause for somebody to have a blood clot. Malignancy would be something else on your differential list, right? You know, somebody's got thrombophilia, their blood clots are being formed, and generally it manifests, like I said, as a DVT and or pulmonary embolism. Like, why does this person have this? They'll often be tested for this factor V Leiden. And if they do have this, or they're positive for this, they generally have to be anticoagulated for the rest of their life because they're going to be more prone to have clots, more common in a Caucasian descent. So factor V Leiden, the coagulation is an acquired hypercoagulability. So know that it causes them to clot and can lead to any of these DIC, liver disease. Here it is right here. This is generally how they manifest. There can be some OB complications, of course, if somebody has this factor V and they have just this kind of hypercoagulability disorder, and these coag factors just cause this person to clot sooner than they should be clotting. And it could include pregnancy loss, preeclampsia, eclampsia, any type of OB emergencies, unfortunately. All right, well, that was very long and it's over. So again, just take up one topic at a time and try to make sense of them. And